My name's Dr. Keith Cunningham. I'm one of the ST2s in obstetrics at York District Hospital. Dr. Wycon very kindly asked me to come and present a case on a complication of a concealed pregnancy. So I'm going to present a case on complications of a concealed pregnancy in a drug abuser as a case report from a patient at York District Hospital. So just a little background. This is again from the recent CMAC report of 2008. To say that obviously substance misuse is increasing substantially in women over the last 30 years. They state that between 2 and 3% of children in England and Wales have a parent with a drug or alcohol misuse problem. Almost 2/3 of drug-using women entering treatment programmes are now parents, but only half of these people have custody of their children. But also interestingly stated that women who are substance misusers, when they enter a rehabilitation programme in their antenatal period, are likely to have better antenatal care and to have better general health than those who do not. So our patient, she's a 29-year-old lady. She attended York A&E department on the 14th of October 2010. That was a Thursday morning. She came with 1 week history of abdominal pain and vomiting. She had no significant past medical history. She stated she was on methadone 80 milligrams a day. She was on what's called the COMPASS program, which is the drug and alcohol rehabilitation program in York. She stated that she lived with her grandfather. She smoked 10 cigarettes a day, but she was actively using heroin at the present time. NA&E, they examined her. They found she was apraxial. She had a sinus tachycardia of 125. She was tachypneic. She was complaining of a painful right swollen leg, and they discovered on abdominal examination that she had a gravid uterus. So the A&E doctors contacted ourselves, and we brought her to our antenatal ward and arranged an ultrasound scan that showed quite a significant DVT on the right side. So it was occlusing her right proximal superficial femoral vein. It was going into the superficial femoral junction, extending into the caudal femoral vein and into the external iliac vein. We also scanned the abdomen to find a single live fetus of about 33 plus weeks gestation. On bloods, it discovered that she was anemic of 9.9. Her MCV was normal. She had low platelets of 74, but she had a high white cell count of almost 20 with high neutrophils. Her clotting profile was essentially normal. Her fibrinogen was slightly increased, which you'd expect in pregnancy. At that point, the lady decided that she'd had enough of hospital for the day and absconded from the ward. So from all that, we discovered that we had one patient with a lot of problems. She was obviously an active drug abuser. She had a concealed pregnancy. She was at risk of preterm delivery with a possible small baby and a risk of postpartum hemorrhage if she went into early labour. There's obviously now a child protection issue because she's an active drug abuser, and there's possible risks if she has preterm labour that obviously the baby will have a dependency. We know she's got a DVT from ultrasound scan, so that, and the size of DVT, she's got a high risk of PE, high white cell count. She could be at risk of pneumonia as well. At this point, we hadn't done a chest X-ray. She's got no anticoagulation on board. She has deranged blood results. She's got thrombocytopenia, and she's left with a cannula in situ. So, if we look at the recent CMAC review, confidential inquiry in 2006-2008, they've implemented 10 recommendations to improve patient care, basically to reduce mortality. So if we look, there's 10 recommendations. There are no specific order of importance. If we look at recommendation 4, women with potentially serious medical conditions require the appropriate and immediate multidisciplinary specialist care. So obviously A&E recognised this. They had a sick pregnant woman and referred her on to the appropriate specialists. And if we look at recommendation 6, specialist clinical care, so identifying and managing very sick women from the obstetric point of view, we recognised a sick lady and we were going to treat her appropriately. Unfortunately, with her drug problem, she left the ward. So from our point of view, we were looking after the patient as we should do. We contacted the GP, we contacted the COMPASS program, and we made the community midwives aware of the lady. She came back over the weekend, always the weekend, came back on a Sunday, attended labour ward complaining of further shortness of breath, chest pain. She had actively been using heroin over the weekend. She was tachycardic, she was now pyrexial, blood pressure was normal. Bloods, HB was normal, platelets had dropped further, she had a high urate, ALT was normal, she had a high CRP, there was a trace of protein in her urine, chest x-ray showed evidence of consolidation, and with a VQ scan that showed multiple PEs. So problem is that we have a confirmed PE, we've got possible sepsis, and again if we look into the recent CMAC report, sepsis is now the most common cause of direct maternal death. It's increased from 0.89 in 100,000 maternities in 2003 to 2005 to now 1.3 per 100,000. She's also at possible risk of preeclampsia. She's got low platelets, she's got a trace of protein, otherwise her blood pressure is normal. There is a risk that she could develop HELLP syndrome, and she's obviously got the problem, she's got continuing drug misuse. That was the chest X-ray that was done on her arrival, and if we look at it, it shows that in the left mid-zone there's evidence of consolidation, that looked like there's an active pneumonia. If we look at the VQ scan, unfortunately, sorry, the pictures aren't very, very clear, but this is a perfusion scan. It just shows on both lungs, there's these little patchy areas that just show multiple perfusion abnormalities throughout, which was highly significant of multiple PEs in her lungs. On the Monday morning, it was decided that she'd be transferred under the care of physicians because it was thought that there was no risk of her going into imminent labour. It was discussed with the haematologist. They didn't think that the low platelets were a result of her just commencing her anticoagulant therapy. Another cause was most likely, they most likely thought would be a reactive thrombocytopenia as a result of acute infection. She was continuing to spike temperatures on the medical ward. They repeated the chest X-ray that showed bilateral consolidation. Blood gases showed she'd gone into type 1 respiratory failure. She has hypoxia to PO2 and she had a respiratory alkalosis, which we can keep in with the pneumonia. And they were querying possible lung abscess, possible endocarditis. It was discussed with the consultant microbiologist, and she was put on Timentin, which is used to treat atypicals and Pseudomonas type infections. So if we look, this was a chest X-ray then that was done the next day, and it shows that obviously this is a worsening pneumonia now on the left lung. It's now spreading into the upper zone, and she's now developing a pneumonia on the right side as well, in the right lower lobe. The following day, we have one part-time alcohol and substance misuse nurse in York District Hospital, and we discovered that, in fact, a week earlier she dropped out of the treatment programme. She was actively using heroin over that period of time. The patient herself had actually contacted the COMPASS programme almost a week before she attended A&E, complaining of breathing difficulties, a swollen abdomen, and she'd been missing her methadone. They'd actually contacted A&E, and the patient had failed to attend. So obviously starting to get sort of a compliance issue picture with this patient. She was able to recommence her on the appropriate methadone. She has got access to the COMPASS programme, and she'd asked the ward staff to assess signs of opiate withdrawal. She only managed another couple of days. On the Thursday of that week, she had a normal delivery, a very precipitant delivery. She was on the commode at the time, and she suddenly felt the urge to push. The obstetric team were contacted. She was found to be fully dilated, and she delivered half an hour later. Obviously, this wasn't ideal. It was in a 6-bedded medical ward. Querying IV access, I think they managed to get a blue cannula in the lady because she was so difficult to cannulate. The obstetric anaesthetic department, they were unaware of the patient, and obviously she was a fully anticoagulated patient on the ward. Thankfully, everything was fine. She only had minimal blood loss, and obviously baby was taken to SCIBU. Following delivery, her HB had dropped further, but her white cells had increased exponentially. They continued to treat her on the medical ward as a query lung abscess, query pneumonia, and they'd done an echo that had come back as negative, and they discharged her 6 days later. But again, on discharge, her HB was 6.9, she had white cells of 23, neutrophils of 20, and a CRP of 258. But unfortunately, at this point, the patient had left before the blood results had come back. They managed to get in contact with the patient the next day, brought her back to the acute medical ward on the 30th, but they only recommenced her on iron tablets, despite the fact that she had very high CRP and high white cells. She then was readmitted 4 days later with a 2-day history of severe chest pain, shortness of breath, lethargy. She was tachycardic. Her platelets had increased further. She now had a white cells of almost 50. She had neutrophils of 42 and a CRP of nearly 400. She'd had a CT that showed multiple cavitating lesions in her lung. She'd septic emboli, she'd consolidation in the right lobe of an empyema, and she was transferred to Hull. So the X-ray, if we have a look, we can see this air fluid level. There's one here, and one here that shows the empyema. And if we look at our CT, so we've got this as a septic emboli here on the left lung, and then on the right side here, this is the air fluid level here, and she's got a large consolidation and empyema on this lung. So obviously it had to be dealt with by the cardiothoracic surgeons in Hull. So obviously this sort of patient that you sort of look through the notes to see sort of what went right and what went wrong. I think initially we treated her correctly, we followed appropriate guidelines. It's only be a part if a patient like this leaves the ward. But I think when she came back was a medical ward, the right sort of place for this sort of patient. I mean, we didn't think that she would go into early labour, but unfortunately she did. She was at risk of PPH with low platelets, and obviously the risk is obviously if we needed to take her to theatre or if we needed urgent care from the paediatricians. Obviously the medical ward in York is 2 floors up, labour floors on the ground floor. Looking through CMAC again, was there appropriate consultant obstetric input? She was reviewed most days by the consultant obstetrician. She did have a daily review by the midwives, but these sort of patients should be reviewed daily by the consultant. The other problem was that the patient had a medical set of notes and an antenatal set of notes, and the problem was people were writing in both sets of notes. So, for example, the compass nurse, the drug misuse nurse, was writing a methadone program on one set of notes that wasn't being followed with because the medical doctors were using the medical notes, so the patient wasn't getting the methadone that she required, which was causing her to constantly abscond the ward, which the nurse thought she was continuing to use heroin while she was an inpatient. And then the appropriate antibiotics. When she was admitted on the second occasion, the medical registrar did review the patient and stated the patient should be on antibiotics for pneumonia. The patient wasn't started on the antibiotics for pneumonia, so should the medical registrar, as someone who's saying this patient needs to be on antibiotics, should this person have prescribed the appropriate antibiotics? And obviously we've got compliance issues with the patient because obviously she was leaving with IV access on the ward, so what she was doing outside. And then obviously suggestions for the future with complicated cases like this is obviously one set of case notes would probably be ideal for a patient like this, because then obviously important notes and information isn't being missed by other members of the medical team. It's probably important to have a daily handover for the obstetric and anaesthetist for patients like this, just so that they're aware that obviously the patient is in the hospital. It happens for most patients in Europe, but unfortunately I think this patient was missed. Is it possible necessary to develop protocols for joint medical, obstetric and anaesthetic for patients like this, so that we have patients like this, it may be necessary to have possible case conferences that may include, the drug rehabilitation services, so everyone is aware of what's happening with the patient. Because obviously if patients like this aren't getting the methadone or the correct treatment, they're going to obviously leave to get it by other means. And we have a midwife at York who deals partly with sort of drug and dependency issues. There's possible need for assessing drug and alcohol services out of use, because in York the Compass programme works Monday to Friday. They only see clients Monday to Thursday. Friday's a paperwork day. So obviously these people have got all the access to the methadone programmes, etc. Well, if they come into the hospital, we can only give them methadone 5 milligrams 3 times a day up to a maximum of 20 milligrams, plus or minus diazepam to settle them down. So if you've got a patient coming in with possibly needing 80 milligrams of methadone, what our protocol isn't really going to touch these patients at all, and that's what could be a reason why she was absconding the ward. So it's just a few suggestions for the future for these complicated patients, because obviously I think part of the problem was her compliance issue as well. That didn't help with the care of the patient. That's everything.
Do you have a daily ward round in the morning, multidisciplinary between obstetric and insulin?
Well, we do. We have a handover every morning, and with the consultant obstetrician anaesthetist. And usually we have a board that patients that aren't on the ward will discuss. We recently had a lady with a brain tumour that there was a large multidisciplinary team meeting. What ifs, should and buts was discussed every morning. But with this lady, it wasn't put on the board, and obviously she was a very ill lady as well. She was in cardiothoracics in the hole for a period of time. So yeah, I think in this case it wasn't handed over correctly on the board.
Dr. Russell?
Was there any discussion of an IVC filter for this girl?
There was a discussion, but the haematologist at the time felt it wasn't needed. They did treat her with fragment at the time.
I just stopped on the second clinical line.
Yeah.
Okay, I think we'll have to stop there and get on with the next presentation. Thank you very much.